We would like to move on to the next presentation, and please hold your comments until all the presentations are done. And Professor Jacquelyn Campbell is going to take us to the next level of presentation. So Jackie, welcome.
Thank you. Okay, and I can control this? All right. Thank you. I have to be in control. No. I need that? Thank you. That's all. It's on? It's on. It's on. I didn't think I needed it. First of all, I'm delighted to be here, and I'm especially excited to get to follow Chi-Chi's, because she and I are definitely on the same page here. And before you decide, oh, she's from the United States, what has she got to say to us? Listen up. I think I have a little bit of lessons learned that will help, hopefully, in the debate and in the decisions about screening or not in this area. So I brought this here so I wouldn't have to keep looking there. But I don't know if I can do both. Anyway, I'm going to talk about this from the Sanctions and Sanctuary framework, which is something that I worked with two anthropologists now almost 20 years ago to start to develop. And it's best articulated in the book To Have and to Hit, which was edited with those two anthropologists. And the notion is that in order to address intimate partner violence, we need to have a combination of sanctions. Now, these are laws, they help, but there's, as was talked about this morning, there's also the implementation of the laws, and that always lags the laws passing, and then actually changing gender norms lags after that. So you can't expect a law to magically change everything. And there has to be the gender norm work that goes on before you can pass the law. So you know already here in Uganda there has been good gender-based norm, good community-based work on gender norms before the laws were even passed and on issues of violence. But you have to continue that work and not expect laws to do it for you. That's only part of the picture. So there has to be community and neighborhood and extended family level norms change work, as well as in the country and in the region. And the notion of sanctuary, Jesse said it well, in terms of safe exit, somewhere safe to go for those women who are being abused. It can be shelters, it can be someone's home, it can be other kinds of NGO kinds of processes, but it must be sustainable, both for that organization has to be sustainable, as was said this morning, but also the woman's economic sustainability is necessary also. So there has to be some sort of resources, some sort of way for her to make a living if she does choose to exit. Also, we always have to remember that most women don't want to exit their home. They want to maintain their marriage, maintain their family, keep their family together, just make the violence end. Now that's easier said than done, we understand. But that means that those of us in the healthcare sector have to be part of that. And that routine screening, routine inquiry is a way to make the healthcare system part of that sanctuary for abused women as they're in the process of trying to figure out how to make the violence end, how to keep the family together, and or the healthcare system can help them make decisions about whether or not they need to exit. Well, you may have to do it for me, Audrey. Oops. Now I went too fast. All right. One of the things that I'm proudest of in life is I co-chaired the steering committee for the WHO multi-country study. And although I didn't actually do the study as people like Charlotte and Jesse did, I helped design it, helped make sure that this was a study of women's health and intimate partner violence. And so one of the things, just to go back to that briefly, is this is some of the data that is the percentage of women who have ever experienced physical partner violence, percentage of women who have ever experienced sexual partner violence, and then, importantly, the percentage of women who have ever experienced physical and or sexual violence. And when we talk about which of those kinds of violence is most associated with things like HIV, we need to remember that what we're talking about is a considerable overlap. And this is a Venn diagram that we did from some of our data. Mary Ellsberg was the first one that did this kind of look, that we have to remember that almost every woman who was physically abused is also being emotionally abused and or controlled by her partner. And that most women, about half of the women who are physically assaulted, are also being forced into sex. So when we think about and when we talk about which kind of violence is it, we have to remember for the individual woman, it's almost always that overlap. And it's those women that are experiencing all three kinds of violence that are the most affected. This is some of the other health outcomes that sometimes we don't think about, and you look at it all over the world, the different poor health outcomes that happen with especially that combination of physical and or sexual violence. And this is, again, data from the multi-country study, and I'm only going to be able to highlight a little bit, but this is in Tanzania, as was mentioned, the one country in the region that was included. And importantly here, I think, is the suicidality that is associated with intimate partner violence all over the world. And sometimes that is a part that's overlooked. So when we do routine screening, we also need to be alert for women being depressed and possibly suicidal. So the United States has taken a little bit different read on the evidence around whether or not we should do routine screening. And in the United States, routine screening and brief counseling was recommended by a 2011 IOM report, consensus report, which you can also find on the IOM website. It's called Clinical Preventive Services for Women. It was accepted, that report was accepted, that recommendation by then Secretary Sebelius of Health in the United States. And part of our new Affordable Health Care Act, which you might have heard of, actually does cover routine screening and, importantly, brief counseling. So it's not just screening, which the United States has decided to take up, but it's some form of brief counseling. Now, what that would exactly look like is not yet totally standardized, but it's being taken into account. Our U.S., the implementation is charged to our Office on Women's Health, and you can find materials about this implementation on that website, which is also from our Gov, is U.S. government. The U.S. Preventive Task Force in 2013 also read the evidence around screening slightly differently than did other people, as Rachel Jukes, who is a colleague and a respected friend of mine, but we differ on this particular aspect. And part of it is that if you read the Macmillan trial, which was in JAMA and has been referred to frequently, I'm there way down at the bottom, buried somewhere on the author list. I was part of that team. And one of the things that you can see in the discussion is a piece that I added, because I think it's very important to understand in that trial that although women who were screened were there, if they said, yes, I'm being abused, that information was given to their health care provider. 40% of those women who screened yes said their health care provider never said anything to them about that information. So they were never given any kind of referral. They were never helped to get to healthcare services. And everybody in the screen group and the control group was given referrals, a written referral list. And all of them actually reported reduced intimate partner violence later. It's just that the intervention group, the screen group, did not report more reduction in intimate partner violence. And all 3 trials that were reviewed all reported decreased intimate partner violence later. It's just that screening didn't make a difference. They all got referrals to domestic violence services. So you have to be careful when you look at evidence in terms of what you're looking at, exactly what goes into it. And I think Charlotte talked about that this morning. We have to be really careful in terms of reviewing evidence, what it says. So screening alone is not enough. Just asking somebody, although we did hear some women are very glad to be able to talk, just asking doesn't do it. We need to help and make sure that those that want to get to services, those that, and it's wonderful when something's on site. So we also need to happen in the emergency department, in mental health, and in chronic care settings, and especially HIV clinics. So the case for routine screening that was accepted by the U.S. Preventive Task Force was, first of all, the prevalence of domestic violence, even in the United States, where it's considered relatively low, is substantial and connected with a multitude of health problems. And if we do indicator-based assessment or routine assessment, or not routine, but indicator-based assessment, the trouble is that there's so many indicators. Will we remember all of them? And will we end up bringing our biases into play? What we found in the United States is that the women who are screened, if you use indicator-based screening, are only those who are poor or of a different culture. So our biases as providers comes into play when we do it just based on somebody's indicators. Women do not disclose unless they are asked. And so we find that when screening is in place, there's far more disclosure, and isn't that what we want? Routine screening is desired by the majority of women in the United States, both abused women and non-abused women, and that's something we've done several different population-based surveys on. And importantly, routine screening creates an opportunity for women to disclose, women that are not yet ready to seek help in the criminal justice system or elsewhere. And routine screening does no harm, and harms were looked for very carefully in the Macmillan trial. We will often, if we do not know that women are abused, miss or incompletely diagnose and inadequately treat a variety of healthcare conditions if we do not know about the intimate partner violence. We do know how to assess, and there's many different tools that have been developed in the United States. They need to be adapted here, but they've been found to be accurate in determining who's abused. And the notion of warm referrals, which is from Futures Without Violence, which is the notion you don't, and you described it perfectly in that study, you don't just say, here's a number you should call, or here's a place you should go, but rather you make sure someone's escorted there. You make sure that they are helped to get to the services they need. And women will decide who and when to disclose to. Just because we ask doesn't mean they're going to decide to tell us. So I would say that the provider who asks badly, and yes, some providers do, women will say, no way, I'm going to tell you I'm abused because clearly you don't know how to ask. We have women, providers in the United States that do terrible things like looking at a computer screen say, you're not abused, are you? So that's asking badly. So who would tell that provider that they're abused? You know, so women are intelligent people, and they'll decide whether or not somebody is someone they should disclose to. and that privacy for screening is absolutely necessary. So the abuse assessment screen is one that we often use in the United States, and it asks several different ways about the intimate partner violence. First, it says, have you ever been emotionally or physically abused by someone important to you? So that's that broad question, like with elder abuse. And then if they say yes, you can go on and find who did it, the number of times they've done it. We oftentimes use a body map to mark where someone's been injured. Has your partner or ex-partner hit you while you were pregnant to get into the abuse during pregnancy? If she's in antenatal care, you can word that differently. During this pregnancy or before this pregnancy. Does your partner ever force you into sex? A very important aspect of this. And then one more chance to disclose. Are you afraid of your partner for some other reason that we don't know about? And this gives women a way to talk about various ways they may be controlled and why they're afraid. In the United States, everybody wants a one-question, gender-neutral thing to do for routine screening. They don't want to have to ask all of 5 questions. And so they've experimented with, are you safe at home? Don't go there. That's a terrible question. Don't use it, even though Johns Hopkins Hospital does. We're trying to change that. But something like, are you afraid or concerned that someone at home or someone you love has or may hurt you or tried to hurt you? And that can be gender neutral. It can also be for any age if you want to do a single question. And then if the person says yes, you have to go on and ask who exactly we're talking about and whether or not there was forced sex. So the purpose of routine inquiry or routine screening is to create an opportunity. It's not for detection. It's to have a place where people can disclose safely. Early, before things get so terrible, they have to go to the police or they have to go to an emergency department. And if they're not ready to go to a shelter. There's also a chance for primary prevention. We can begin routine screening with a statement that helps us get into it and also teaches people something about violence and the health effects. In order to do an accurate and complete diagnosis and appropriate treatment of a host of conditions, not for detection. Amongst pregnant women, we found that women are not embarrassed, angry, or offended, but they do worry about disclosing if they think we're going to notify child abuse kinds of entities. So that's one thing you have to make clear to pregnant women. Challenge is implementation, and what will this brief counseling look like? As I mentioned, we have an issue if providers ask badly, and if providers actually include some probing questions, providing open-ended opportunities to talk, as that woman said, in order to disclose, and being generally responsive to women's clues. The system also matters. There needs to be clues in the environment. We care about domestic violence. We found that posters oftentimes help in the environment, in the clinic, to let women know that this is a clinic that is sensitive to intimate partner violence. And saying something to begin with, because domestic violence or intimate partner violence happens to so many women, we are asking all women these questions. So she doesn't think we've signaled her out for some reason to ask her, so she's not offended by it. And we also use as an opening line sometimes, because intimate partner violence or domestic violence results in so many health problems for women, so we're teaching about that connection. We're asking all women. We use a lot of times notices in restrooms. We use information about shelters in women's restrooms because that's someplace you can go privately. We have to change forms oftentimes, and that is a challenge. There needs to be incentives and training for the staff, and providers knowing, like in the study that you talked about, Chi-Chi, that there's in-house backup for them. That if they get into a situation about domestic violence, they're just, it's overwhelming that they know that there's somebody that can help. And we found, again, like you did, that it resulted in increased patient satisfaction in emergency departments where there was routine screening. Patient satisfaction overall with their care was, for women, was increased if they were asked about abuse. And as has been said, the strategies cannot just be imported. I encourage you to do the work here to see what we're using might be adaptable here. When Jessie reminded me about Suzanne Maman's work, I remembered that one of the things she did with focus groups in Tanzania, she asked women, what does emotional abuse, where does it cross the line between, calling names, fighting, to emotional abuse? And the women in Tanzania said a line I'll never forget, it's when it hurts your soul. And now that's somewhat different from the controlling behaviors, but that also is incredibly painful to women, the emotional abuse as well as the controlling behaviors that we talked about this morning. So moving forward, we need to identify the best of brief counseling. Is it this warm referral, perhaps associated with a few other teaching points that we can give to women, and a few other, give her choices of where she wants to get services, further services. If you have a gender-based violence clinic, that's terrific. There may be a shelter close by. There may be the opportunity to work with another provider, a mental health provider, some way of getting the male partner into some sort of program that will help him become less violent. And also, many times women are mostly interested in the effects on their children, and that they want mostly to get some sort of help to help their children heal from this experience of trauma in their homes. We need to incorporate domestic violence prevention and interventions. We have prenatal home visitation, but you definitely have a great system of antenatal care. What kinds of things can be incorporated into antenatal care? It's incredibly important, and the Dove intervention in the United States is one that we found very easy to put into prenatal or antenatal care, and I can get information for you on that. It's a very simple brochure-driven intervention that has promises to be adapted. It obviously depends on the context, what healthcare setting you're doing the routine screening, the availability of this in-house domestic violence advocacy. Do you have trained social work available for this? And the woman's preference, who she wants to talk to, where she is, in several different processes. First of all, in the process of recognizing that it is abusive behavior that's happening to her. It is a problem. It will affect her health. It will affect her children. And in terms of her commitment to the relationship, does she want to stay married? Does she want to continue this relationship if it's a dating violence relationship? Because if we talk to her about going to a shelter and she wants to keep this marriage going, that may not make sense for her. And so she may need to get the gender-based violence NGO services outside of a shelter setting. And we have to be clear, we're not trying to destroy families here, and that's something that oftentimes healthcare system policymakers really worry about. And we're with most of the women on that in terms of not wanting to leave their family setting. And I'll finally end up with the HIV settings. We've talked some about the linkages with HIV. It's incredibly important that gender-based intimate partner violence and also sexual assault be incorporated in all of our HIV prevention, our HIV testing and counseling services, but also in our HIV positive clinics where we give HIV care. One of the things we're doing in the States is we have found that the stress, the toxic stress, as was mentioned, is not only harmful for children, but it's also incredibly harmful to women. And we find their immune systems compromised, dysfunctional immune systems as a result of intimate partner violence. And that dysfunction of the immune system is both overaction in the immune system and actual compromise of immune system. So it both can increase your susceptibility to infections. Think about it. STDs, et cetera. And also having that STD increases the transfer of the HIV virus across the vaginal wall. So we also have that stress response increasing a woman's vulnerability to HIV if she has an STI, which abused women are much more likely to get from their partners and husbands. And then we find that once she has HIV, again, that immune system compromise is part of what's happening to her. Not only may she be afraid of disclosing HIV for being beaten, but she may also have her HIV positive status go more quickly to full-blown AIDS if she's abused. And we've seen that in the United States. I know I'm out of time, but let me end with one story from an HIV clinic that was treating persons with HIV, whether or not they were HIV positive or had full-blown AIDS. This is in the United States. This is for women. And I know in the United States you say, well, that's nothing compared to our challenges. Everybody's getting the full complement of the antiretroviral drugs. They're getting exquisite health care. But we still had, in an HIV clinic in San Francisco, we had 6 women die within a month. And the providers said, well, we have to review these records. This is untenable that women are dying from HIV under our care. They were all on antiretroviral drugs. They were all had good CD4 counts. However, 2 of them, the one thing they had in common is they all were being abused. 2 of them killed themselves. 2 of them were murdered by their partners. And the other 3 had trouble maintaining their antiretroviral regimen and had gone back and forth and therefore had complications of AIDS that they died from. And so the one thing in common was they all were being abused. And so that really galvanized that clinic to provide care around domestic violence for all their HIV positive women. Thank you.
Thank you very much, Jackie. Jackie got extra minutes, 1 for being a co-chair, and 2nd, because in her last slide of moving forward, she helped us write a policy brief for the parliamentarians that didn't come today. So I think it's really been a very, very powerful summary that can talk to the policymakers that usually don't have time to go through so many papers. So I hope that we take that last slide very, very importantly. And 2 other things that she's also done is to point out to the fact that the so what question is very important when we're discussing some of these issues. So somebody saying, if I did, if I screened, if I disclosed, so what? And this so what translates into 2 ways. 1, in terms of the services available, but also in the consequences to the person who is going through this process. And finally, I think it's really a simple thing, but sometimes we forget it, how to ask. And so as we discuss, I think we should also, have this conversation on how do we ask. I'm sure that we want to be asked nicely. So if we do, why don't we want to do the other